Good afternoon, Team UHN, and Happy New Year. This is the first open forum we've held since 2021 befell us, and I want to welcome all of you back. For those of you who had some time off, I hope you had some time with your family. I want to especially mention all of those of you who worked during the holidays and were unable to be with your families, and say a sincere thank you. I also want to thank all of Team UHN who's been working at this for now going on to 11 months of COVID. And I know you're tired, and I know it's irritating at times, and I know things are imperfect. I just want to remind you a couple of good news stories. So from Wave 1, we're no longer debating PPE. That's great progress. Also from Wave 1, trying to work through what it means to do redeployment. So lots of good things and lots of learnings. I know we're having some learnings in Wave 2, and there'll be challenges. As you know, we're going to talk about some of those today. For those of you who were working on Christmas, again, I want to particularly thank you. I know a number of the executive team were able to come in and talk with a number of frontline staff, and it was very gratifying to be able to do that, and also get some feedback about what you were struggling with, facing. And most importantly, see those patients who, particularly with COVID disease, but also other critical illnesses, were struggling. So thank you for your care of them. Obviously, we're now entering a phase where being a team is going to be more important than ever, and it's easy at points of fracture where we get frustrated and where people have different opinions. So I'll ask you to try to remain united. As General Hillier has been fond of saying lately, friendly fire is just as deadly as enemy fire. And by that I mean we need to have respectful discourse. But I know during today's session we're going to talk about some difficult topics, and there are strong feelings on it. But at the end of the day, we are united in doing what's good for patients and being kind to each other. And so with that, I think we have some real opportunities to continue to strengthen what being a member of Team UHN means, how we live our values at UHN, and how we move forward when errors or less than perfect outcomes occur. You'll all have seen over the holidays, and a number of you have written me, that leaders from across public and even some private sector organizations made decisions to travel. And I know that many of you were very upset about that. And that included UHN leadership and followership. I know that there are some very strong feelings about this, and I want to talk about those today. I know that many of you feel that this goes against our value system and that you expected all to follow public health advice, and I want to come back and talk a little bit about that. We did send out a reminder on December the 21st about travel, but as in Wave 1, what we ended up saying was if people chose to travel against advice, that they needed to isolate upon return. And I want to talk to you a little bit about the evolution of that a little bit later. But although this applied to a number of people, I understand, at UHN who made that decision, one of those members was a member of the executive team, Keith Stewart, and Keith traveled to Arizona. As you know, Keith joined us not so long ago, a recruit from the Mayo Clinic, and his move was not yet complete, but Keith would like to make a few comments to you, and then I'll come back and answer a few questions that I've received in my mail. So over to Keith.
Who may be on mute.
Keith, if you're muted, you'll want to unmute.
Nope, I'm here. Thank you, Kevin. I was just unmuting. Kevin, thank you for giving me the opportunity to speak directly to the staff, and good afternoon to all of you. I know that many of you have read and were disappointed and even angry about the story in the Toronto Star last week that documented my recent travel to Arizona. Clearly, the trust which people have placed in me as a leader in healthcare has no doubt been eroded, and the reputation of UHN and Princess Margaret potentially blemished, which is especially troubling during this acute medical crisis, during which public support and confidence in University Health Network is critical. So I'm sorry my trip has caused the institution, especially our dedicated staff, additional distress. I will do what I can to reestablish your trust through my actions and through my dedication to building confidence in our institution. I'm currently working from home, and I'm using vacation days for this period of quarantine. I look forward to being back at my desk next week as we together navigate the Princess Margaret Cancer Programme through these turbulent times, and as we continue to put the needs of our patients first. In closing, I want to thank you for listening and for the opportunity to say I'm sorry that this has happened, and to express my renewed commitment to the cancer program and to University Health Network. So thank you, and I will turn it back to Gillian and Kevin.
Thanks very much, Keith. I'll just add a couple of other comments. So I did get a number of emails from staff, and I did then have the opportunity to follow up directly with Keith as well as with Diana. And just to be fair, in order that we treated everyone fairly, what we're discussing with Keith and what Keith has described in terms of working at home from vacation is exactly what other employees are doing. So while I don't want to minimize this issue in any way, I also don't want to suggest that some of our physician colleagues and our leaders should have a different standard in terms of expectation following an error. And I think we all make errors, errors where people recognize them, try to correct them, and move on is what Keith has described today. I also know, or I've heard, I haven't talked to anybody else, that a number of you have pointed out there may have been other people in leadership roles, maybe not on the executive team, but in leadership roles across UHN. I'm unaware of who those individuals are, but I have sent out some documentation about what we should do going forward. I also took the liberty of talking to someone with a bit of an ethics background just to discuss this issue because it was so important to me to get this one right. And one of the things they reminded me of is the border was not the issue. It was travel outside of our region. And I know a number of us traveled outside of the region, probably unknowingly. So people who have second homes in cottage country, a lot of people didn't follow those rules to the letter of the law. And I think we all want to take some renewed interest, particularly today, when the Premier has just announced the kind of numbers modeling might suggest, and they are staggering. They are going up to, in late February, possibly 12,000 positive cases a day. So now is the time for us to be more vigilant than ever. And one of the things that I will commit to doing is ensuring that each of you know what is the public health advice, because another thing I learned was it wasn't all that easy to determine public health advice from who? From PFAC, from the Public Health Agency of Canada, from the Medical Officer of Health for the province, from the Medical Officer of Health for the City of Toronto or the region in which you live. So it's a complicated issue, and we'll continue to work through it. With that, I know that there are a lot of questions, and I'll try to come to those as we get into the question session. And I'll now turn it back over to Jill.
So thanks, Kevin. Just a few words, not about the travel situation, but really about the way people are feeling at the moment. I think people are tired. I think they are on edge. I think those who are caring for people are frightened or at least anxious. And I can feel it in myself, what that does. It makes us shorter. It makes us, I guess, more judgmental. And the only way I think we will get through this is if we work together and really cut everybody some slack. Last week, I probably answered about 1,000 emails in the vaccine. There were many, many kind comments, and there were some very unkind comments. And while I understand that people take out their frustration, I think we all have to check ourselves a bit and go, is this really necessary? And am I contributing to the solution here? So with that, I don't usually editorialize.
Good. A little editorializing in the new year is good.
But I think now we'll move to the travel questions, which are up on the screen.
So let me try to move through these and give you some highlights. And obviously, I invite any of you who'd like to talk about this to reach out to me directly. The first question about Keith's travel again, is this the leadership? It isn't the leadership we expect from UHN. UHN signed off on it. I can't understand how this is okay or why Keith's family needs are more important than anyone else's. And clearly, any of our family needs are equivalent. And one of the things that I reflect on is many people have been deprived. And you know what? I'm really sorry for that. When Keith mentioned to me that he was going, and I was aware that Keith was going to Arizona to complete his move. His family and children and wife were there, and he had some elderly parents or in-laws who were being cared for. So I was aware of it. I have to confess I didn't think about the public health rules, and I should have. That having been said, again, I also didn't think about that for those who are choosing to leave the region of Toronto, and I hope you'll each think about that, particularly now. So no, there is no separate set of rules. As a matter of fact, and you'll know this from my previous comments, I expect executive team members and other leaders across the senior management forum of UHN to be above the standard of behavior, not at the standard of behavior. We have to model it most. That having been said, I hope during my tenure here I've always demonstrated that an error is forgivable. A contrition is an important part of being human, but when people flagrantly disregard that, if we had an individual who was constantly traveling, this occurred and they continued not to take heed, then of course we'd be into disciplinary action and termination. That isn't the case with anyone that I know here. And for those of you who've identified some other leaders in the organization, medical or medical practitioners, if you want me to have a conversation with them, please let me know. I'm not aware of it's a very large place, so I may or may not be aware. I've heard rumors. I'll reach out to those I've heard rumors about. But I have every confidence that all of them will I'll hear contrition from. That having been said, I was also struck by, particularly amongst our fellows and a number of others, people whose families are abroad, where they may have sick and elderly relatives, and they haven't been able to go home for almost a year. So I'm extremely mindful of this, and again, want to make sure that our team is flavored with compassion as well as with the appropriate rules. The second question around, are people being paid to work from home? Well, under the quarantine, Keith has already indicated that he's taking his vacation time to do that. What we haven't done at UHN, and I have discussed this deeply with Diana and Human Resources, is if you were able to work from home after being abroad, historically, up until this incident, you were able to do so. Since this incident, we've been clear that if you choose to travel at a time when public health is advising against travel, that it needs to be either unpaid if you can't do your work from home, or if you are doing your work from home, then it needs to be well supervised. The next question talks about on September the 25th, I've asked our leaders who see non-compliance to suspend staff members who show no contrition or repeatedly offend, and that absolutely remains clear. I will forgive anyone at UHN or anywhere else for that matter who makes an honest error and who made that with judgment at the time. In retrospect, that judgment may have changed, but at the time. And so I hope you'll continue to see this to be a place where we try to be kind to each other and understand that as humans we make errors. Lack of change when your errors are pointed out is the concern, and I don't think we'll have any more issues with that. Leaders and politicians are traveling. I have not seen family. And Kevin, you've stressed the importance of following guidelines. It does not seem right that there are two sets of rules depending upon your hierarchy. You know what? There aren't two sets of rules. I want to make that perfectly clear. This issue, starting with the finance minister, really clarified for all that that particular behavior is not acceptable, and we've seen a number of CEOs in Ontario lose their jobs over it. Particularly as CEOs, I think we have a responsibility. But that having been said, again, I want to just reinforce, I suspect, I don't know this, but I've certainly, like you, heard rumors of others, be it frontline staff or managers, who have also been away. And so I am not interested, frankly, in the middle, or hopefully approaching the end of a pandemic, to go back and do a gotcha game with people who are members of Team UHN on the front lines. If you made that error, I'd ask you not to make it again going forward. And again, if you have individuals who you feel aren't complying with the isolation rules or the protection rules following making that decision, now in retrospect a decision in error, then please again let me know about those. If these leaders do not follow guidelines, I think that's so the question of how do you expect staff to, it's a great question. And I think now today's numbers more than ever demonstrate that, boy, everyone is going to have to radically change their behavior in the coming weeks if we're going to avoid that 12,000 people a day. We know that our critical care space is already challenged, and I think for us to get to a point where critical care is protected and every Ontarian who needs care can be provided it, this is now in our hands. And for most of us who work at UHN, we have the ability to make the choice to affect those issues carefully and considerably. There are some people, however, that we need to be much more attentive to, and those might be individuals who are living in underhoused situations or living with multi-generational families or whose economic abilities are not great because of their personal circumstance. And if any of those individuals exist at UHN, if you're struggling with those issues, I want to invite you to reach out to Human Resources so that we can try to do our very best to support you at a time when we know this is the population who are most at risk, those who are most challenged by Advantage. So we'll continue to work with you on that. Have any UHN leaders traveled internationally during the pandemic? The only one I'm aware of is Keith, who's come forward very openly. I've heard again some other rumors of staff and physicians and scientists who may have. I will be reaching out to them as I know about them, but I don't believe that there are a great number. Again, I do want to reinforce the outrage of international travel. I know is what's caught everyone's ire, but the other piece is just to remind you, many of you do consider traveling to your vacation homes. You maybe have a Collingwood chalet or a cottage. The advice now is do not travel to those regions either. So I welcome feedback from you as to whether we're looking at applying the rules equivalently no matter where you travel to or only internationally. I think the medical officers of health would be clear. It's anywhere. So as we enter this next very challenging phase, please follow those rules. And again, we'll put them on the COVID website so you can see what they are. When executives leadership travel, they have the privilege of working from home upon return. A healthcare worker with a similar situation does not. This is never acknowledged. So you know what? I think Keith's decision to take his vacation was an acknowledgement of that. So he is both working from home on his vacation and losing the time as a result of that. And obviously for clinicians and others who have to be on site, it is an impossibility to do your work from afar. I wish that wasn't the case. What's your response to Dr. Stewart's travel to the Dominican Republic over the holidays? I think it's very similar. So I know Dr. Stewart well. I know that system very well. I spent many years of my life working there, a great group of people. And I think, obviously, as CEOs, we are the bellwether of the organization, and people wanted accountability both in Hamilton and in London. I always try to have human sympathy for people, for colleagues who have had their life turned upside down by a bad decision, and I would have that same sympathy for each of you, and hopefully we could try to work through those issues and move forward, and I know that we will. But I realize CEOs have a separate standard, in the privilege of sitting in this chair means that you have a higher expectation of behavior, and even though the error may have been just that, an error, there are consequences when you've lost the confidence of those who you lead. And while I regret that for the individuals, I understand that the reactions of the organization were swift and the boards had to act.
So those are the questions related to travel. I think we'll now move on to, I guess, more traditional COVID. And we're going to have Dr. Susie Hoda walking us through the current state of COVID-19, and then we will follow that with a finance update from Darlene Dason. Susie, over to you.
As this up with the numbers, I think we can see that, globally and within Canada, it's quite staggering the number of cases that we currently have clocked in terms of COVID-19. I'll just jump forward to what's happening in Ontario. So currently we've been recording anywhere from around 3,000 to 4,000 new cases per day in the last couple of weeks within Ontario. That's quite the jump from probably the last time that I gave this update. And we are also tracking what's happening with the number of new cases of variants of COVID-19 that have been emerging across the world. So in the last 24 hours, there are 8 cases that were found in Ontario of the what we're calling UK variant, recognizing that this is probably a global variant now. It was just first detected in the UK. Here in Toronto, we have 837 cases in the last 24 hours, and the areas within the province outside of Toronto that are also hotspots include still Peel region, York region, more recently Niagara region as well. So speaking to some of Kevin's points about, moving around within the province, you can see how rapidly the epidemiology can change, and we certainly don't want to be contributing to that by, going from our hotspot to other areas within the province. As you know, we've been in this province-wide lockdown since December 26th, but here in Toronto earlier than that, so November 23rd, and we are expecting to hear more in terms of additional restrictions that may be announced later today. Here at UHN, we have 75 patients with COVID-19 admitted to our sites, which includes 27 in our ICUs, both Toronto Western and Toronto General having these patients, and 48 in inpatient units across Toronto Western primarily. That's where we have the most. Toronto General, but also some at Toronto Rehab. And that speaks to some of the outbreaks that we've been experiencing. So as numbers of cases go up in the community, and within the hospital, so do our risks for outbreaks. We've had 3 units in outbreak at the Bickle Centre over the last couple of weeks, and we just declared an outbreak at Toronto General for MB over today, so that was good news. And we have a recent outbreak that was declared at Toronto General 6 Eaton South the last couple of days. So keeping a close eye on what's happening within the house as well as outside of our house. And you can find our numbers updated on a daily basis within the COVID intranet page.
Thanks very much, Susie. Now over to Darlene, who's going to talk about the finances.
Great. Thank you very much, Jillian. This pandemic has been very far-reaching, and it actually has had some quite substantial financial impacts as well. I'll just spend a couple of minutes and just provide a high-level overview of the financial impact of COVID-19. We did put a process in place at the beginning of the pandemic to capture all of the COVID-19 costs, and these are primarily costs, but not for the pandemic, we would not have had to incur. And we submit these costs on a regular basis to the government for reimbursement. Our last submission was actually in December, just before Christmas. We put our last submission into the province. And I'll just walk you through at a high level what those numbers were. So today, we've actually submitted $245 million in COVID costs to the government for reimbursement, and that is both the federal and provincial government. The great news is that we've actually received just over $210 million of that has already been reimbursed to UHN, leaving an outstanding amount of about $35 million. And you may ask in terms of what's actually in those costs. Well, the government has put out guidance and guidelines to help us understand what qualifies as a COVID-19 expense. And for UHN, our claim primarily included the costs of our staff, all the incremental hires, some of our bridging salaries. It also included all of our equipment and supplies and all of the PPE we've had to purchase for the pandemic. And it also included costs for some of the building work and some of the renovations and maintenance that we've also had to do. We have included in there as well the reimbursement to UHN for the work that we've been doing in long-term care and other congregate settings and our COVID assessment centers and all the various initiatives that UHN has been leading and or working on. They've been reimbursed through these COVID funds. So that's been very good news. We do have, as I mentioned, $35 million outstanding, but we do expect these reimbursements to continue. So in addition to those amounts that we've received from the federal and provincial government, we also, as you may recall, had some generous donations from our foundation, particularly early on in the pandemic, which was very helpful to help us to support staff. So overall, I would say it's a fairly good news story in terms of the reimbursement of our costs. We do have some residual financial challenges. There are revenues that UHN normally would earn, but we've been unable to earn during this pandemic. So we are working with the ministry in terms of how to best manage those. And those of you out there who have a penchant for financials, who may look at our financial statements, can see that our working capital is starting to erode. But I can say that with these COVID-19 funds, we do have sufficient cash to manage the operations at UHN. In addition to that, we also expect these reimbursements to continue not just to the end of this fiscal year, but given the current trend of cases, probably into the first quarter of the next fiscal year as well. So I'll stop there, but if you have any more specific questions related to the financial impact of COVID-19, please feel free to reach out to myself or reach out to the finance director in your portfolio. So I'll hand it back over to you, Jillian.
Thanks very much, Darlene. It is encouraging to know that so much has been recovered, and I guess encouraging to know that the government is moving quickly.
Yep.
Kevin, if you want to say anything about our
I want to thank the Government of Canada and the Government of Ontario for ensuring that this cash flow occurred rapidly. It wasn't an easy thing to do, as you all know. The Auditor General's waded into a number of these, so governments are treading carefully and lightly, but also expeditiously. So, you know what, I think it's great news. We'll obviously have a reconciliation when this is over, but, you know, and at every turn, every government decision maker, be they a public servant or an elected official, has been really fantastic in saying, tell us what you need, tell us what the team requires, and we'll do our very best to try to help you. And they're doing exactly that.
Okay, our next topic is vaccines. And
Yes.
Kevin, I'm going to ask you to lead off. I've been calling it the vaccine maelstrom, but I'm sure
Yes, there is. Yes. So first of all, I want to thank so many people who've done an amazing amount of work to get this up and running and do so quickly and ambitiously. At the head of that pack being Jin Hu and Emily Musing, Michael Caesar, Leanna Graham, John Granton, Tamara Duss, Ian McDermott, and Rebecca Ripa. So I know this has been a tireless team in working, and I know that there has also been frustration, particularly frustration among a number of workers who are working on the front lines. And I want to just assure you that we are doing the very best we can in a command and control structure with a very simplistic IT system. I don't mean that in a negative way. No one's ever done this before. We're talking about inoculating, 14.5 million Ontarians, even to get to the target of 70% or so. We're talking about 10 million people. So it is imperfect. You'll recall when we received the vaccine, we were the first in the province and in the country, as well as our peers in Ottawa. And one of the things, right after Christmas, there was a hue and cry, an outrage that vaccines remained in freezers. And right away, General Hillier, who's been chairing the task force, and Premier Ford and others said, that must cease immediately. We want vaccines in arms. And so there was a call to march, and people mobilized, and we set up some amazing centers both at Michener and at Mars, and I want to thank all of the staff who participated in that. You'll recall that we started with long-term care, and first of all, I'll just maybe make a couple of comments that divides our Pfizer supply from our Moderna supply. And in a minute, I'll ask Sharan to talk about the Moderna supply because we're delivering that to long-term care homes. The Pfizer supply, as you recall, very complicated drug, has to be stored at minus 70 degrees. When you take it out, it has to be mixed with saline, so it's a lot of work on behalf of our pharmacy colleagues. And despite all that, we got this done remarkably. And I want to thank Camille Lemieux and Sharan and Brian, and I'm going to forget people and I'm going to be embarrassed, and someone's going to tap me on the shoulder and say, don't forget also to mention all of the folks who are out on the front lines in these homes doing really remarkable work for the people who have been hit hardest by this pandemic, long-term care residents and long-term care workers. Back to our Pfizer supply. So as you know, it's an IV mix, and as we drew it up and mixed it and tried to operate our clinics, we heard very clearly from General Hillier, get this in arms. No more vaccines sitting in freezers. We are going to do our very best to get more, and we're going to get it as frequently as we can. And so that's exactly what we did. We took those instructions, and we'll continue to take those instructions. I think one of the hardest parts about this illness is people coming to understand a vaccine strategy that says we're doing everyone in a red zone before we might do a patient-facing person in an area where there are no cases. So I know that's hard to imagine because we're seeing people online saying, I'm an ICU nurse, or I'm a family doctor, and I live in an area and I haven't got my vaccine, and you're already inoculating people in Toronto and Peel and Halton and places like that, it's because they're red zones. And really, until we inoculate the majority of people in those zones, it's not protected. And I just want to remind folks that this is a disease passed on by community acquisition. Most of the disease has not been passed on in the hospital, and even the outbreak, Susie will comment on this in a moment, that you've heard about at UHN, almost every single one has started with a community-acquired case. So there will be times when the logic seems to be, let's inoculate everybody who works with patients directly. In reality, that they may or may not be, more often not, the people where this disease starts. It starts in community settings where people are challenged, particularly with housing and with being able to separate and with being able to mask and follow public health measures. So that having been said, I think we did a fantastic job, but that fantastic job was imperfect. And when you're trying to do this big a job, it will always be imperfect. The biggest imperfection, I think, was trying to get the people closest to those treating COVID inoculated immediately. And Emily's going to talk about what we've done and what we're thinking about doing next. Before doing so, let me turn to Sharan. No, Jill's going to change things. Are we on the slide, Jill?
No, it's okay. We're going to show a screenshot of the dashboard that's been created.
Okay, sorry about that. So here's another great piece of work, and I want to thank the IT team and all the folks who've been looking at the total number of vaccines administered. 14,489 vaccines, 9,000 of them being Pfizer, so they would have been delivered almost exclusively, not exclusively, but almost exclusively here at sites of UHN, and 5,367 delivered in long-term care homes. And one of the things I hope you will be most proud of, as I am, is that about a week ago, UHN finished all of its long-term care and retirement homes, thanks to all of those amazing people.
Yeah. I think the vaccine team worked very hard to get the content up today. I also have to say that the public affairs web team worked very hard to get this up over the weekend. And these numbers will be updated every day.
Yes.
I think the difficulty is the supply. We can't give shots if we don't have the supply.
And that, Jill, is not, we do not have a clear line of sight to that. So as many have said, we are infantrymen and women, and the task force is the General Hillier, but we are being instructed to implement, and we need to continue to follow those directions. Also, not only from the General, but from Toronto Public Health, who was challenged with inoculating the entire population.
Okay, so we're now going to move on. I'm going to ask Sharan Isaacs, who's on the phone, to talk about what we've been doing in long-term care. Sharan.
Great, thanks, Jill, and good afternoon, everyone. As Kevin and Jill have noted, over the past 2 weeks, UHN has established mobile vaccination teams to assist in vaccinating all of the City of Toronto long-term care and retirement homes with our Moderna vaccine. We are happy to report that we completed the first round of vaccination of all of the UHN homes this past Friday. And so we're now focusing on the completion of all homes in the city, hopefully by the end of the week. I also want to acknowledge and thank Dr. Camille Lemieux and the Toronto Western Family Health team that have been out in these homes with the mobile vaccination teams for the past 12 straight days. One of the reasons we've been able to move so quickly has also been as a result of the strong partnerships that have been established with all these homes as a result of the leadership of Dr. Joy Richards, Dr. Susie Hoda, Lori Seaton, Brenda Perkins-Mengas, Leah Gitterman, Joanne Bridle, and many others that I apologize that I may have missed. With our collective efforts, we have now vaccinated, and I think this is our real-time number, over 6,000 residents, staff, and extended caregivers in these homes. I also want to share that what we've heard and seen as we visited our long-term care homes and retirement homes with the team. For any of you that are following Dr. Brian Hodges' Twitter feed, you'll see the sense of hope and excitement from the residents and staff, and it's been incredible. And in many instances, as the mobile teams are coming to the home, they're being received with cheering, welcome signs, and an overall excitement. In talking with some of the staff in the homes, it's clear to see that there's a sense of relief that they know now that the residents that they care for so deeply are being protected. I know the vaccination teams are also sharing how uplifting this work has been to date, although tiring. Finally, I just want to acknowledge the incredible work of the Connected Care team, who in 24 hours stood up a joint operations center to support all the mobile vaccination teams across the city. And in partnership with the amazing UHN pharmacy team, Alton Health, our supply chain teams, and along with the family medicine teams across Sinai Health, Women's College, and North York General, we are now able to vaccinate up to 1,000 individuals a day, and we're excited to continue to help deliver hope to many of our at-risk populations in the coming weeks. Now I'll turn it back to you, Jill.
Thanks, Sharan. Kevin has a few comments, but what I also want to say is I want to thank Brian Hodges, who has been photographing this and been in every single home since the beginning. Hope is an important thing, and Brian's journey with this has been to document the hope, and I think it's very much appreciated. Kevin?
Absolutely, and I also want to thank Brian, because not only I think has it helped the journey and helped keep the staff upbeat and help people understand the amazing progress, but it's also helped some vaccine potentially resistant folks here realize and see that this is a safe vaccine to get, and how many residents and frontline workers in long-term care have chosen to get that, which we know in some homes is a challenge. So Brian has become a photographer extraordinaire. He will be known as the Karsh of healthcare going forward. So Brian, thank you. I also want to do a special thank you to Tamara Duss and her team and John Granton. And folks, you will be aware at UHN, we are by nature, a critical appraisal environment, right? We're always looking at how things could be done better. And I welcome the fact that you're continuing to identify how we could improve things. But it is a massive plan, and please know and understand that while imperfect, we are trying to work with the rules we've been dealt by the Vaccine Task Force, as well as get the maximum number of people through. After Emily makes a few comments, I'll come back and comment on the last weekend and a bit of skirmish with the media around some people who may have signed in to get inoculated that would better have waited. But let me come back to that after Emily.
Okay, so I'm going to ask Emily, our VP Clinical and Chief Patient Safety Officer. She is on the phone and will give us an update about all the work that's happening.
Thank you very much, Jill. Thank you. So I'm happy to have the opportunity to provide an update about UHN's vaccination centers and clinics. So as you know, we currently have 2 clinics open. The first one was Michener, which opened December 14th, as Kevin said, one of 2 pilot sites in Ontario. So that site has 9 vaccination bays. We're able to actually provide up to 500 doses per day. And the learnings, in fact, that we had from opening that site were put into a playbook that was shared with the other hospitals that now have the ability to provide vaccine in their own clinics. As well, we have our second site, which is Mars, that was opened on January the 5th. 12 bays allowing us to vaccinate approximately 1,000 doses a day. And based on availability of supply, both sites can be open 7 days a week for 12-hour days. So once we also have enough supply to justify expansion, we plan to open a 3rd clinic at the BMO Center at Toronto Western. So we're ready for that. We're just waiting for supplies. I want to let you know, as of yesterday, we vaccinated 6,441 doses. I think that's including today's doses for Michener, as well as over 3,000 at Mars. So that's over approximately 9,500 doses between the 2 sites. So you may know that initially our focus was on long-term care staff because we were reaching a large proportion of them. We were able to expand to hospital healthcare workers. And our current breakdown shows that approximately it's about a 40% split to 40 to long-term care, 60 to hospital healthcare workers based on who we vaccinated. We have also provided 400 doses of vaccination to Bickle. This was in response to the various outbreaks that were happening on that site. We want to stem further outbreaks, and these doses were used both for staff as well as for patients in those areas. Our priority groups are really designated by the Ministry of Health. So just want to remind everyone that our current prioritization of groups for who should receive vaccination at one of our UHN clinics remains long-term care, healthcare workers, and essential partners linked to Toronto Home, as well as healthcare workers at UHN, Sick Kids, Sinai, Toronto Grace, and Women's College, and then specialty groups such as those that are designated to go into specific areas to administer. For example, Orange is flying individuals to remote Indigenous areas, and those individuals need to be vaccinated. So I want to say, I know Kevin's going to speak more to this, there are times when we do receive word that other hospitals have extra doses or unfilled bookings. This happened recently both with Michael Guerin and with Southlake. So in these cases, we have a very short window in which to inform our staff so that they can go onto their system, book, and receive their doses at these alternate clinics. The principles remain the same. We try to reach those that are working in high-risk patient care areas, followed by other patient care areas. In the case of Southlake this weekend, this was done both by email and also a phone fan-out. We also did provide the same information to our partner hospitals. Now, due to the large number of open bookings that still remained at Southlake, we then made a decision to expand provision of information to areas beyond our patient care areas, such as for researchers working with live COVID. Our goal, dependent on having sufficient supply, remains steadfast. What we want to do is to provide 2,000 doses a day through our clinics, 500 at Michener, 1,000 at Mars, and once we're able to open BMO, 500 at BMO. If we do receive adequate supplies, our aim is to try to finish vaccinating staff who are working in high-risk patient care areas and then other patient care areas within the next few weeks, with the goal of then vaccinating everyone within Team UHN within the next month. Again, very much dependent on supply. So far, 2,578 staff that have identified themselves as linked to UHN have or are today receiving first doses through our clinics, and 54 have received second doses. So UHN takes approximately 47% of those that are in the hospital category that have received doses so far. I'm just going to sign off now, and Kevin can jump in to answer more.
Yeah, so thanks a lot, Emily. A number of you will have seen some media over the weekend, and then last evening I had a chance to clarify with Kelly Grant from the Globe what occurred on the weekend, which was exactly as Emily described. First, a significant push out to those who were in the priority groups, group what I'll call A and B, who are on COVID units, who are on clinical units, who have some risk of exposure to patients under investigation or patient care areas. When those were not filled, and there are a number of reasons, timing, including some people who were working that day, but we then said, so let's look a bit more broadly and tried to fan out. Again, in the spirit of the General's direction, speed and getting needles in arms, let's look at who else might be available if we can't, and we really did beat the trees to try to find more frontline staff, unable to do so. One thing that did concern me was, frankly, as a academic health science center and the leading research institution in the country, a bit of pushback like, well, researchers shouldn't get inoculated. Remember the fact that without research, you wouldn't have this vaccine, number one. And number two, the researchers that were identified were people who are working with live virus. And there's about 500 people, principal investigators and their staff. And I absolutely stand behind that decision that people who are trying to cure this disease through further research are also very important ingredients immediately behind those who are doing direct care. So just clarity on the importance of research and researchers here at UHN for me was very important to share with you. That having been said, I don't know of a perfect vaccination plan that's been rolled out anywhere in the world yet in COVID, and we're looking at it daily. There are some problems we're trying to solve, and Emily and the team and our human factors folks and others are going away and thinking about, do we need other interventions beyond these large clinics? Do we need some visits to particular areas of the hospital? Do we need some different scheduling opportunities for subsets of employees? And stay tuned, we'll have more ideas for you within the next 24 to 48 hours. But suffice to say, nothing could be more important. Just want to close by reinforcing it is all dependent on us receiving vaccine. If we received vaccine at the levels that Emily's described, so doing 3,000 a day, we would be able to complete the rest of UHN in about a week, everyone at UHN. And remember, this is a disease that fulminates in community spread. So it all comes down to how quickly we get the vaccine, and that is by no way, shape, or form blaming anyone. The province, the country, this is the most valuable commodity in the world. Everybody wants it, and we are fighting for our share. So again, stay tuned, be kind to one another, and errors are unintentional, but frankly likely because of the scale and speed of this exercise. We welcome any of your feedback on how we could do it better. I know it's frustrating. Always request that you give that feedback in a respectful manner because people are working really hard to get this vaccine to you. Thanks.
Yeah, I don't think I'll editorialize on that. So we're going to move to the questions here. And the first one, and I think, vaccine questions. Sorry, well, I'm just very conscious of the time. We may not get to any of these questions here. Yeah, go ahead, Kevin.
So Emily and I'll dovetail on these two. So question one, most popular. Vaccine information seems first to go to UHN higher level staff with quicker access to emails and computers. Porters, PSWs, environmental services, and other staff members that are not given allocated computer time are missing the ability. How's it being addressed? Thanks for a great question. John Granton actually brought this up today. Ron Swale assured us that all of those staff now have, I understand, both access to computer time and UHN emails, as well as their private emails will be available for them to register. I totally get that when you're working, if it opens up, you're disadvantaged, and we're thinking about what we can do better on that. Our mathematical geniuses are thinking about whether to hold some back. Again, while still not overcomplicating this and slowing us down, because the goal is still get those needles in arms, and frankly, if we slow down, we will not be the hospital that gets the next shipment. Right? You have to be pretty close to being out when everybody wants it this badly. So the best way we can get you more is by being efficient in its delivery. Emily, anything I've forgotten?
No, I think you got the crux of it. I think over the next little while, what we're going to focus on is how can we get spots linked to the specific high-risk areas, whatever they are, that are being identified, and get those people vaccinated. So there'll be various strategies we're working on there.
And that's question two, which is, and Emily's answered it. Will there be anything done to ensure high-priority personnel get the vaccine, like ICU nurses? Absolutely. So for the last few days, we've been thinking about options with that, while again thinking about efficiency and limited staffing, and the ability to transport the vaccine and the safety issues required. But again, stay tuned. 24 to 48 hours, we'll be out to you with some strategies to do that. Do we have a responsibility mandate to vaccinate our community patient-facing healthcare workers first? So, i.e., non-hospital affiliated MDs, NPs, social workers. We all have an opinion on that one, and unfortunately, it's not our call to make. So the province of Ontario has made that decision. I support the fact that they made the decision to first do long-term care residents, where the mortality is about 72% of those who've died in this disease. I think few of us would debate that. Followed by the staff who serve them in long-term care. Those are the individuals who, unfortunately, through no fault of their own, most of the time, are bringing it in through community spread. So I think that's been true. The next level is a risk-stratified approach, and the task force, informed by good evidence, has made the decision that it is now patient-facing who have COVID or who are in acute environments. One of the reasons I surmise, no one has told me this, but if you think about UHN, to introduce COVID into our transplant program, our cancer program, our cardiac program, our GIM program, where we have many frail elders with comorbidities, the mortality would be dramatic. The good news, and I'm in no way, shape, or form minimizing the remarkable contributions of our community colleagues who've really been responsible for this vaccine blitz, is we are not seeing large transmission among frontline providers, and that's obviously thanks to good IPAC process. So that one's going to be a debate.
I think another point on this is that if the people in the hospital get sick, we won't be here to care for the community people who need hospitalization.
Right.
So as much as it feels unfair, I think the other thing is public health is the place that is
Yes.
really accountable and responsible for delivering vaccine to people in the community.
Yeah. And red zone, and you know what, I have to reinforce, the red zone model really does say red zones need to get done before other parts of the province have vaccine redirected because of community spread. Sorry, I'm a broken record, but just want to reinforce, how does this disease spread? It spreads when we gather in our communities. The next one, will UHN be offering employee family members the opportunity to get their vaccine after staff vaccination? Frankly, we have no idea. That will come back to the public health agenda and the General's task force, so we will raise that with them. I know that Dr. Davila today put out some information around mass inoculation environments in Toronto. So we'll make sure that we communicate to Team UHN where your family members can get it as quickly as possible once they're eligible in terms of grouping, and also ask the question, if those sites are exceptionally busy, we've completed our staff and the staff of other healthcare facilities, if there's a possibility to use our internal capacity for your families. I'm aware of non-patient facing receiving immunization despite not being patient facing. Can we refine the scheduling? So I wish I could tell you that we have a very robust, super sophisticated scheduling system. We don't, and we didn't design this, and it's no criticism of people. We're taking the COVAX system, which is a fairly simple system, understandably, because of the massive numbers, up to 15 million of us who will want to get inoculated, we hope. And we really can't do that well. So what it is residing is your personal responsibility not to sign up when your group is not priorized. And I don't say this as a scare tactic, but today Jill and I had a call from the Ontario Provincial Police saying, we saw some of the media about people queue jumping, and we'd like to know why you didn't report that to us. And to be honest, I wasn't aware that it was a reportable offense to the police, but if that's the case and the task force so identifies, then we'll share that with you. I will call the OPP officer back to get further information. You'll know that this is an issue now in the media across many, many, many hospitals. So obviously stay tuned on that one, but please, like everything in healthcare, the honor system and our integrity is the most important thing we have. If your group is not called upon, then please don't queue jump, and please do not share the link we send you. It is meant for you, only you, and if we mean it for other people, we'll send it to them. We've had a number of examples where we've had to clean up by, again, people in their zeal sharing the link, a bunch of people going on, and us only having to say, sorry, you're not eligible, if we could catch them. The other piece is we do not have unlimited resources to pile over the data. So we really are trying to, again, get this done quickly. And I apologize for saying this, but the onus is on each of you to only register when you're the key group. And right now, that remains the frontline priority staff, COVID facing.
I think it's also incumbent to say that every person who works here contributes. And so the people in IT, if they don't come into work, we won't have a system if it goes down.
100%.
But the groups who are actually working with patients are first.
Yeah, and it's a risk stratified approach. So we will get there. Can you expand and give specific details on what these checkpoints are? To Jillian, given you stated our vaccine clinics have checkpoints to ensure only eligible staff. Jill or Emily, anything you want to say on that one?
I think Emily, or I don't think Leanna's on the call. Emily, are you still there?
I am. So can you repeat that question? Sorry.
So when I go to a clinic, Emily, can you please give examples of the details of how people check in to ensure they're the right client to receive the vaccine when they go there?
Right. So right now there's a series of questions that people need to answer as they're booking into the system, which is that first check. So we rely on people, on their honor system actually saying the truth and answering that. And at that point, they are booked in. From that point on, when people show up for the clinic, what we're verifying is they are the individual that is booked in. So we're reliant on all hospitals as well as ourselves opening up the link and the password to the correct group of people, and that those people do not share the link with other people that are not supposed to be booking in.
And Emily, I think the question also implies when I get to the vaccine station, when I go to Mars or BMO in the future or Michener, someone's saying, are you among this group? Are you the group that we're inoculating at that point in time?
Right. At this point, what we're checking when people come in, and Tamara's on the line, so she can correct me, what we're checking is that they have their badges and that they are hospital and or long-term care individuals. I don't know that we are specifically going through the whole question again with regards to the priority care. Tamara, please jump in and help.
Right. At this point in time, we have been going by the honor system. We may have to change that, but we are trusting that the people who have been pushed out the links and are signing up are the people that are supposed to be there. So we do check for the hospital ID and their OHIP cards, but beyond that, we've not been doing more.
Thanks. The last question of this section is based on the email timestamp. Research staff were offered vaccine slots in Newmarket before clinical staff. And Emily has the timeline more than I, but I don't think that's correct. We actually started with clinical staff the night before when the Newmarket colleagues were able to very quickly put together a booking system and give us a link. So later on Saturday evening that went out again on Sunday morning, and only after, I think we were at about 400, just shy of 400, when we said there's probably another 300 vaccines or so that's available. Rather than waste them, as per the order, get needles in arms, let's open that up to additional groups. So it's roughly 300 vaccines that were potentially used by all hospitals in our grouping: Sinai, Women's College, UHN, Sick Kids, and the Grace. But Emily, am I correct on that order of communication?
Yep, that's exactly correct. There was a day, if not several hours, of us and many of our leaders doing mass fan-outs, emails, personally trying to call people in the first priority list with people working in high-risk patient care areas, and then expanding to other patient care areas before we even considered opening it up further. And it was based on the feedback that we were receiving from our leaders that they had tried every way they could to get a hold of people that were in the higher priority areas.
So I think now we're going to probably only have time for a couple of the top questions. Jill, is that okay?
That is correct. So the first question, this would be for Susie and anybody else who could answer it. Can you still transmit COVID to other people after having completed the two-step vaccination? Susie.
So I think the short answer is we don't entirely know. The clinical trials that study these vaccines show that they're about 95% in terms of efficacy in preventing symptomatic infection in those who receive the vaccine. That really was what the studies looked for in their endpoints. We don't yet know if you could still have asymptomatic or very minimally symptomatic infections and shed virus and transmit to others. But it just reminds me that it's really important that people continue to follow all the public health messages, the infection control messages, including masking and distancing after receiving your vaccine. And it also just kind of reminds me that, we have to think about what we're doing when we're vaccinating here. We're trying to protect the individuals who are getting vaccinated from experiencing the harms of COVID-19. So there's still a lot of value and utility in getting the vaccine.
Okay, thanks, Susie. So we're going to do two more questions. The other thing that I want to say right off the top is many of the questions that we have addressed today are in the lineup of questions. So we've had topics where there have been a number of questions. So the next one, many of us, and this is for Diana, I think, and for you, Kevin, possibly
and also Dar. There's a little bit of a financial implication.
Yeah. Many of us were not able to take vacation in 2020. Yes, UHN released the restrictions for carryover. However, being realistic, it is unlikely we can take all of our time in 2021. Will UHN consider an option of having vacation paid out? So I think maybe I'll go to Darlene first, because there is a huge financial implication behind the question. Darlene.
Yeah. From a financial perspective, we do actually accumulate on the balance sheet, and we do have set aside the funds equivalent to the vacation owed for employees. So from a financial perspective, we do have the dollars set aside. I think we'd have to work very closely with our HR colleagues and also connect with our peers to understand what's being done from a system perspective in terms of paying out vacation. But financially, it wouldn't be a barrier.
Anything you want to add, Diana, and then I'll give you a couple thoughts.
Yeah, thanks, Kevin. So what I would say is from a system perspective at this point with the Tasman hospitals, we're not considering paying it out. We're at the very beginning of the vacation year, and although we're at an extremely busy time right now, certainly from my perspective, I think people need to take as much vacation as they are able to take this year. And I think later on in the year we'll have a better understanding of whether or not there is a need to pay anything out. But would really want individuals to take the time rather than the money, to be honest. Kevin?
Yeah, so I think the next question speaks to this one, and I think it is about your well-being. So I echo Diana's. If you're able to take the time, that would be ideal. I know many of you are not taking the time because of your dedication to patients and are frankly being very short-staffed, especially as we continue to open beds, and these numbers continue to be daunting. So I think two things. One, yes, we will absolutely consider this one. Two, we again can't set provincial policy, so we'll take that back to the Government of Ontario as well as to our Toronto Academic Health Science Network table to see if there's others who are considering similar approaches. And hopefully at the next meeting, we'll be able to bring you up to speed on this one. But first and foremost, we know many of you need some time off. If that's possible, please do so for your own well-being. If that's not possible, we certainly will consider if this option's doable, which financially it is. Now is it from a policy perspective and the rules of the Government of Ontario?
So this will be the last question because we're over. So people, we are already stretched thin. My colleagues and I, nursing, pharmacy, NPs, physician assistants are tired, and now we're getting a new surge unit and an increased patient ratio. We're getting more responsibility but less resources or no increase in staff. My concern is our mental health and our patient safety. I'm going to ask you to address this.
Yeah. You know what, I absolutely share this concern, and it's a daily part of our discussion. Sadly, for those of us who are looking at the numbers, and I want to thank Marnie Escaff and Susie and Rebecca and a few other colleagues who are on the GTA IMS acute care table. As challenged as we are, some of our colleagues around us, Trillium, Osler, Scarborough, it's even more challenging. Their numbers are up at 130 or 40 COVID patients daily. So we will absolutely, we're recruiting. Every time we open a bed, we're trying to find new staff. As you can imagine, they just don't exist. So the other model that we're going back and looking at is, are there any extenders? Are there people like those who do resident care support and long-term care that could help? Are there PSWs that might be available? Sadly, again, a massive shortage. But we are very, very mindful of this one and need to think about both our models of care and the physical layout of units to maximize the number of staff that are there. I wager, based on the numbers that have been released by the modeling table today, that this is likely to get worse without behavioral change and without a change in transmission rate. So we are very mindful of your well-being, and we're going to be attentive to this to the degree possible.
So that brings us to the end of the session. Kevin, any final words?
Yeah, again, you know what? As we start a new year, we started with the hopefulness of a vaccine. And I think, again, we should remain extremely hopeful. The one way to solve the vaccine problem, of course, is as we see other good vaccines safely approved by Health Canada, that will help us get that flow occurring. And if we're lucky, we'll go from thirsting in the desert for it to swimming in the ocean of it. And then we can get everybody inoculated quickly. With that, I also want to be very mindful. The Premier will be making some changes today. Those changes will affect all of us and will ask us to change our behaviors. I want to ask each of you as colleagues and Ontarians to really follow those rules judiciously. If any of you are experiencing personal difficulties in doing so, please reach out to us through Human Resources, and we'll see if there's anything we can do to better support you in following those rules to the letter of the law so we can eradicate this. Thank you, and again, Happy New Year.